everyone. Welcome to the LeadingAge Kansas Statehouse Chat. I am your host and Director of Government Affairs, Rachel Monger, and I am excited to welcome our guest today, Secretary on Aging, Sean Sullivan.
Good afternoon. Great to be here with you.
Well, thank you so much for being here. Actually, I'm calling you Secretary on Aging, but pretty soon your job title is going to change.
Yeah, it could possibly change. There's a proposed executive reorganizational order, or what's called an ERO, that'll go out in the next week or two from Governor Brownback, and part of that proposal is to bring the disability programs that are currently at SRS, combine them with our traditional aging programs, and our department would become the Department for Aging and Disability Services, or KDADS. Great name, isn't it?
It is.
I am the #1 dad, so I should be in charge of KDADS.
And you will be the secretary. What are we going to call you?
Secretary of Aging and Disabilities.
Okay.
SAD.
Sad.
Mm-hmm.
Okay. Well.
We apologize for the poor humor.
Well, we do appreciate you being here to talk to us today, and we wanted to hear from you about the long-term care budget.
Sure.
So when we were looking at the budget, currently we're in state fiscal year 2012, and that will end July, maybe June 30th, and then fiscal year 2013 starts July 1st.
Correct.
So for the nursing home program, when we were looking at the budget, they have a, I don't know if you call it a caseload, but the number of persons served in 2012 was 10,020, and it's projected to stay the same in 2013. But when you look at the projected expenditures, it's $6.6 million less than this year. So on the surface, it looks like maybe is there a potential for rate cut? We just want to know how that would work with the same amount of people but with less money.
Actually, there are not any anticipated rate cuts as part of the fiscal year 13 budget. It appears there's a decrease in spending from fiscal year 12 to 13, but that is tied to the provider assessment or the quality care assessment. In 12, we were required to pay back the temporary 10% cut that occurred in fiscal year 2010, and that happened. So it's actually flat rates from 12 to 13 and then flat caseloads. So there will not be any anticipated rate cuts at this point.
Well, how about we move on to the home and community-based service, the frail elderly waiver. We heard from the administration, especially when it comes to Medicaid reform, it's very important to you guys to reduce the nursing home utilization rate, which would mean, we presume, moving more people into home and community-based service programs. And so when we were looking at the fiscal year 2013 budget proposal, we saw that for 2013, you're actually designating $1.2 million less than this year. So what is going on with that? How does that match up with your goal?
We do anticipate utilizing the HCBS program more as we move into CanCare, knowing that the CanCare changes will come 6 months into the fiscal year and will start January 2013. But that'll be a budget neutral difference. So if we have 100 less people in nursing facilities, if we have 9,900 instead of 10,000 approximately that we have in the caseload budget, then we will have 100 more that'll be on the HCBS budget. And because of the the higher spending in the nursing facility average per member month as compared to the HCBS budget, it would actually be less in the total budget. So we decided ultimately to leave the caseloads the same. The difference in spending that you reference on why you see a decrease in the HCBS budget is due to policy changes that we made the last fiscal year in fiscal year 2012. And those two things were a program called Financial Management Services, or FMS, and the second is a program called Electronic Visit Verification Systems, or Authentic Cares is what the product actually that was implemented a week or two ago. With the FMS, that is for, on the HCBS waivers, there are 5 different waivers between SRS and aging where self-directed care is an option, where the caregiver can hire a friend or someone in the community to provide attendant care, housekeeping, those kind of things for them. CMS and the federal government does not allow the state to pay their wages directly to the client, so we go through a fiscal intermediary. In the past, those payroll agents or the fiscal intermediary has received a lump sum that included the wage and the administrative portion that the state gave them, and then they determined how much they were going to pay the worker, and then they would also determine how much they're going to keep as an administrative rate. CMS mandated that we change that system. We agreed with the need for that. There was a lot of fraud that was built within that system, with the payroll agent system. As a result, last November of 2011, we went to the program called FMS, and as a part of that, the administrative rate changed from $140 a month per client to $115 a month per client, which is still above what the national average is of $98 a month per client. And that change from 140 to 115 saved the Department on Aging and SRS millions of dollars that was built within the budget. The last budget year, there wasn't a full year, or this budget year we're in now, there wasn't a full year of implementation built into that. Between July and November, we were still within the current system. So as we go into budget year 2013, we're anticipating the full 12 months of that rate change from 140 to 115 as it's implemented. And then the second thing with the electronic visit verification system, or Authentic Care, that was implemented January 16th of this year. Again, that's just that we're anticipating savings by reducing fraud and abuse, but within the HCBS system. The fiscal year 12 budget was built around 6 months of implementation of that. The fiscal year 13 and the governor's recommended budgets a full 12 months of savings from that program. So the overall spending for our elderly HCBS for our elderly program is down, as you noted. The caseload remains stable for what we have budgeted. The rate that we pay to providers remains stable. So really the reduction in total spending comes from the FMS and the electronic system that we put in place.
Well, my next question would be, discussing rates, is in, I believe it was November 1st, it was supposed to be enacted a 10% rate increase for assisted living, residential health care, and Home Plus providers in the HCBS program to make up for losses they saw after the time standardization with the plans of care. So our question is, are we going to see that 10% rate increase continue on into fiscal year 2013?
We have that 10% rate increase built into the budget. It's really a revenue neutral deal because of the policy changes and the changes of units for the 1,400 HCBS customers that are in assisted living facilities that were impacted by this. So the 10% increase in pay that went in effect November 1st corresponded to the reduction in revenue due to the unit changes and the policy changes. We have forwarded that on in the 2013 budget, and it would continue as we move forward.
The last question I have regarding HCBS and the state administration's policy on incentivizing community services rather than nursing homes is one of the problems we've run into is in rural areas, a lot of times the nursing home is the only resource there for long-term care and for aging folks. And so we are interested in hearing any ideas, programs, steps your agency has made in incentivizing building that kind of capacity, one, and then two, if any of those potential incentives would be worked into the budget for 2013.
I don't anticipate them being in the 13 budget. As you know, we convened a work group that included several LeadingAge providers and members, and then several KHCA providers and members, and several advocacy organizations along with our staff. Probably September, October, to look at what other states have done in regards to incentives to allow nursing facilities to diversify and get more into HCBS settings and increase the capacity where we need it in rural and frontier areas of the state. I believe what that committee ultimately decided, as Joe Ewert and I worked with them, was we needed more data. So we As part of this CanCare process, we are issuing a request for proposal in the next couple of weeks to universities to help us, number one, help us create a more uniform assessment tool between the frail elderly waiver, the PD waiver, the developmentally disabled waiver, the autism waiver, and the technology assistance waiver. Right now, each of them have different documentation, different uniform assessment instruments to different scores, and CMS wants us to come up with a more uniform tool as we move into this new system. So they're going to help us do that. And the second thing is CMS now allows states to restrict eligibility based on scoring. And what they've said, effective last summer, was as long as, for instance, on the FE waiver, you do not make it more restrictive for a senior to live in the community, so you don't take the current score that you need of a 26 and lower it, or take the current score of a 26 and raise it to say you need a 46 to be on HCBS. As long as you leave that at 26, you can make it more restrictive to say you need a 46 to be in assisted living, you need a 66 to live in a nursing home if you're on Medicaid or HCBS. We haven't decided whether that's a good policy or not. That's something that we want to have discussions with managed care companies as we move forward in the next year and sign those contracts on whether that's something they would desire. We don't know of any other states that have done that, but we want to look carefully at that possibility. And as this university helps us determine the assessment tool, we also want them to look at a possible tiered scoring system as well. And then the third thing we've asked them to do is to look at the capacity needs that we have across the state based on the assessment tool and based on the scoring. Even if we do not have a scoring system in place, we do know that we anticipate a certain percentage of our customers and clients in nursing homes now, or elders that live in nursing homes, could be served in assisted living or could be served in other HCBS settings. The question is where, how many more do we need, what capacity is needed around the state. So we're going to have that university look at those things with us and do a statewide capacity study for us. So an example of what that might look like is they could tell us, based on the assessment, based on your data, based on your scoring, in Emporia, you have right now 100 too many skilled nursing beds, but you need 200 more assisted living, you need 100 more of this, you need 200 more of that. That would then help us know what incentives we need to put in place to build that capacity in Emporia or in McKinney or Logan or Atwood, where we have those needs. But until we know what the assessment tool is going to be, until we have someone take a harder look at the data and where the needs are across the state, it was hard for this group and hard for our agency staff to determine what incentives we wanted to forward on. So it still is our desire to do what some other states have done. Pennsylvania, for example, did a focused shared savings program to where if a nursing facility provider agreed to go from, for example, 60 to 40 beds and use those beds for assisted living HCBS, it would save the state X amount of money, and then the state then returned that savings through an increased HCBS reimbursement. So that's a possibility. There are several other states that have done various forms of incentives, but we ultimately felt, in conjunction with the providers that were part of this work group with us over the fall and winter, that until we had more information, until we had more data, that we really couldn't form a good policy on what incentives need to occur. So we're going to be working on that between now and the end of the year, and then hopefully we'll have a better idea of where we're going.
And hopefully you'll reconvene another work group once
Yes.
the study's done.
We certainly will. When we have more information, have more data, we will reconvene. This obviously is a very important thing to us. As we move forward into CanCare, it's a lot easier to affect change in Topeka and Kansas City and Wichita than it is in rural areas of the state, where in Cimarron, Kansas, Gene Bryant Shepherd Center is the only nursing home, only healthcare provider there. So we want to be able to provide incentives that help Gene diversify, provide HCBS settings, whether that's assisted living, home health. So the care, the senior needs at Cimarron is available, and not just her nursing home. Nothing wrong with Gene's nursing home, but there's a certain feeling that there's premature placement in a lot of areas of the state where there's no other providers currently.
Well, we we look forward to seeing that study, working with you guys on that. How about let's move on to your favorite and talked about topic, I suppose, is can you give us an update on where CanCare is right now? I know you've been in front of the legislature a lot lately. So if you could give us an update, that would be great.
CanCare is my favorite topic. I'd be happy to talk about that. As you know, the request for proposal, RFP, went online to the state website the second week of November. And since that time, there have been a couple of things that have happened. The first is there have been 2 pre-bid conferences, and that's through this process when managed care companies have questions about the request for proposal or about the details or the questions we've asked. They all write in questions to a central agency here at the state. We compile those and then we send out the answers so they're all uniform and every managed care company bidding on this. And also providers have the same information from the state. So we've had 2 rounds of the pre-bid conferences and Q&A sessions. There have been roughly around 1,000 questions and answers that have been fairly detailed. Those are available on the KDHE website, or that you can also access it through the KDOA website. Is great reading material for when you're wanting to go to sleep, I might suggest. So that's the first thing. The second is kind of the next step in this process is the technical aspects of the bid are due January 31st, so here in about 10 days or so. And then the second part of the bid, which is the financial terms of the bid, are due on February 22nd. Once the bids come in, the financial bids come in on the 22nd, then we'll be able to release the companies, whether it be 6, 8, 10, that actually bid on CanCare and the contract. But we will start, after the first part of the bid comes in, January 31st, we will start with state agency level of evaluating several different aspects of those bids, whether they relate to level of innovation that comes with it, or whether it relates to how the health homes will be created that we've called for, how care coordination will happen, how they're going to maintain choice among the network, how they're going to build their network, some of those things that we have requested in the RFP. So that'll all continue, and it'll be a very, very arduous process, really in February and March. That'll require a lot of the time of Department on Aging, SRS, and Health and Environment staff as they evaluate very technical portions of probably 8 or 10 bids. As you mentioned, there has been a lot of legislative questioning and oversight about CanCare. We've gone through, I think, about 2.5 weeks of hearings and questions and advocacy testimony in either the Senate Public Health and Welfare or the Senate Ways and Means Committee. We're now winding down on the Senate side, and we're winding up on the House side through the House Health Committee, the Social Services Budget Committee, and the House Appropriations Committee. So we view this as a very helpful process. We welcome legislative oversight. There's been a proposal that there's currently a joint House and Senate Health Policy Committee that meets throughout the year. There's been a proposal that committee be shifted towards focusing on CanCare and providing proper CanCare oversight. We welcome that process, and we want to see that actually happen, whether that's through a statute change or just a policy change. So we will be working very closely with them. Really, our timeline continues as it is, with the deadline for the bids and continuing the process and working on the evaluations. And we still expect for this to move forward and for contracts to be signed in June, and then that'll then start the 6-7 month time period for ramp up, rollout, implementation, building a provider network, enrolling consumers into CanCare with the implementation date of January 13. So we will continue to answer questions as we need to through the legislative process. We encourage your members, any other members, consumers, family members, providers to continue to come to us with any concerns, questions, whatever it may be. And we will do our best to address those or send them out through you. We did have one provider web chat and telephone session 2 or 3 weeks ago. We thought that was a good tool to utilize. We want to have more of those here in the next couple of weeks, and then try to do those every month. So there's a lot of changes happening. We need to make sure that we're being as transparent as possible, that we're providing as much information as possible to providers who this greatly impacts, and so we do desire to do that and work in partnership with LeadingAge to do that for your members.
We have a few questions we could ask you, and
Okay.
we've been keeping an eye on you at the legislative hearings
Yes.
and listening, and there are some common questions among provider groups and among legislators that come up repeatedly. And so, how about I ask you some of them?
Be happy
and you
to
can
answer
share that
them.
with our viewers. One of the major questions is, why so fast?
Yeah, that is one of the most commonly asked questions when I'm out making presentations, or has been one of the concerns of legislators and the associations is why you guys moving forward with this and implementing it January 1st. And the answer is we looked very closely at the timeline, and really we felt like we had a year planning time period from January of 11 to when we finalized the proposal and announced it in November. We felt as we looked at other states that was actually quite a bit more than many other had utilized to develop policy. And then from November to when we signed contracts in June is a 7-month process. And again, as we looked at other states, we felt like that was pretty comparable in kind of a middle of the road type time frame. And then the third part of the process from signing contracts to roll out in January 13, again, is another 7 months. And I think that's what probably is causing the most trepidation and concern. And again, as we looked at other states, Florida, Kentucky, Texas, Tennessee, and so forth, some did it in shorter time frame. Kentucky did it in basically 3 or 4 months. Others phased it in over the course of a year or two. Other states phased it in by region. Ultimately, we felt like we need to get this going as quickly as possible to allow all consumers to be in this. And really, we're actually continuing to phase in. About 280,000 of our 380,000 Medicaid consumers are already in one form of managed care setup or another, whether that be through mental health or whether it be through the Health Wave type program. But really what we're doing is adding the seniors and disability populations to the equation. We feel comfortable with the timeline. When we go through this and before and after we sign contracts, there will be a very comprehensive what's called readiness review that our state staff will do to ensure that the 3 winning bidders are ready to go online in January, that they have their billing processes defined, that they have their authorization processes defined, that they have their provider networks developed or will be developed. So we anticipate there will be glitches, as there are with any change, and this is certainly a very significant one in terms of dollars and impact and the number of people and providers. But because as we looked at other states, as we looked at this readiness review, we feel comfortable that this is a reasonable time frame, and it's a good time to do it at the beginning of the calendar year of January of next year. And as far as the number and the significance of the changes that will be occurring once this happens in January, I think changes will be slow to occur. I think the first thing that'll really happen will be for those that have Medicaid and are providers of Medicaid, they will see the payer change from the state to these 3 managed care companies. That'll be obviously a huge change, but we will prepare them as much as possible. We're looking at whether we can have a common billing platform, such as what we have now, that could ease the burden. The second thing that we would expect probably to happen right away in January and in 2013 is to look more closely at the supply going into nursing facilities and to the HCBS waiver programs, and making sure that if a person can be served in assisted living or can be served at home, that's being done and that's being expedited and the process is being moved forward. But that'll be a slow change over time. We don't anticipate a huge sea of change with the percentage of people we have in nursing homes. It'll be probably a 5 or so year process. The third thing that we would expect we'll see immediate impact is a conflict-free process that we're putting into effect that will cause the HCBS waivers to be a lot more scrutinized than they are now and a lot more managed than they are now. And then really the fourth change that we expect in 2013 is the implementation of a health home. And really encourage your members to find out more about that. They can go to the RFP. They can look at what's been done in other states. North Carolina is a great example, and I know there are LeadingAge members in North Carolina that are part of the health home network there. And it's been a tremendous success and is much of what the health homes that we hope to have within CanCare and how they will be, we hope to have them structured. So the first 12 months of CanCare in 2013, we've called for health homes to be implemented for any consumer that has a mental health condition and diabetes or another chronic care condition. So they're very clinically complex, very difficult to care for consumers. And then beyond that, we've called for the implementation of these health homes for all Medicaid consumers within the first 2 years. So even that will be a gradual kind of phase-in type approach.
Well, I think you did touch on what was going to be my second question, which was the potential administrative burden on providers and doing the billing, getting payments from 3 companies.
That is a concern. It's something that Deborah and Rachel have brought to the table as we started talking about this several months ago, as they checked with their counterparts in other states that have gone a managed care type direction, is concerns about billing and timeliness, and was one of the reasons that we were fairly adamant that we put in very restrictive guidelines about clean payments, clean electronic submissions, about training and assistance that has to happen within the RFP and also will be in the contract. So we have put in very defined timelines, actually more for nursing homes than any other type provider. I'm going to be pushing, while we go through negotiation process, that what we did put in for nursing homes as far as payment guidelines and timelines, hopefully we put in for the rest of the, whether it be HCBS or mental health centers or physicians. I think what we have in for nursing facilities needs to be in for everybody. Whether that happens, I don't know. But this is creating a more complex process to where your providers are going to have to deal with 3 vendors instead of just the state of Kansas for Medicaid clients. So that is a concern. We've tried to address it as much as possible on the front end. It also creates more burden with authorizations and some of those things that are now relatively simple within Medicaid program. So we have tried again to build some of those concerns. We'll try to build and contractually address those. We have called for that the managed care companies will collect client or patient obligations for all Medicaid consumers, not just for nursing homes clients. So I think that's a very important trade-off, knowing as a former provider how difficult that sometimes was to collect payments from families or residents and some of the abuse that is built within that system. Hopefully that will ease the administrative burden, and it'll be a nice trade-off for having to deal with the billing for 3 providers instead of just one state. So we will continue to work with you all on that. We don't want it to be we want to ease into this and want to create as many efficiencies as we can, as many commonalities between the 3 winning bidders as we can, and we'll be looking to you all and your members for feedback as we move forward on that.
That's good, because I'm sure that's one of the more immediate concerns we're going to be running up against. So it's good to know that we can come to you about that. What about PACE?
A couple of things. That's been a frequent question is how does PACE fit within CanCare? We want to do a couple of things. The first is for our 2 sites that we have now, Via Christi Hope in Wichita, and then the second, Midland and Topeka. We want to expand those number of slots, and we really will be asking them how many slots they want and how they're going to be able to have that expanded access while still meeting state and federal requirements. But we want PACE to be a dual enrollment option to CanCare. So for a consumer in Wichita that's 55 and older, that's dually eligible for Medicaid and Medicare, they would be able to go and enroll in Via Christi Hope or one of the 3 CanCare companies. That'll be the winning bidders. And the same here for Topeka. It'll be really a revenue neutral type decision, because if we have 300 more people in the PACE program in Wichita than we do now, really that's not an additional budget line item increase in spending, because that would be 300 less people that would be in the CanCare program, and the rates will be somewhat similar as we move forward. So the first thing is expanding Topeka and Wichita. The second thing is we desire to expand the PACE hopefully fairly quickly into Wyandotte County, our 3rd major population area. And the third thing that we desire is to expand PACE throughout the state. So At some point this year, hopefully within the next 6 months, we'll put out a request for proposal, and we'll ask providers to respond back to the criteria we set, and hopefully we'll have a number of bidders that will be interested in establishing PACE programs throughout the state. We've seen it be a very successful program. It somewhat mirrors what we're trying to do with the CanCare program as we move forward. I think there are some things that will have to happen at the federal level to make PACE a viable option in rural and frontier areas of the state. But we are trying to work with CMS on creating some of those flexibilities. So I think that'll be a great opportunity for your members and something that hopefully they will look very closely at.
Thank you so much for tuning in. This is the first of what we hope will be several more videos throughout the session with different people up here in Topeka and on the Hill. So once again, thank you very much, and we'll see you next time.